So Texas adopts in 2003 major tort reform, cap on non-economic damages, other anti-med-mal measures, has a very dramatic effect on med-mal claiming rates. So claim rates go down by about 60%, payouts go down by about 75%. And so you might then ask, what difference does the reduction in med-mal risk make to anything other than med-mal risk? And one question you might ask, which is in a separate paper of mine, is there any apparent effect on healthcare spending? And the answer to that is not that we can find. So if you think that med-mal reform is a magic bullet to control healthcare spending, it ain't. This project is about, is there any effect of med-mal risk on healthcare quality? Okay. So this project, unlike the other one, we have an exogenous shock to med-mal risk, so we can hopefully say something about more directly about causation. And so we're going to ask what happens to these PSI rates as markers for healthcare quality, hospital quality after reform. We're going to look at individual measures, we're going to look at pooled measures, and our control is going to be other states. Okay? What happens to PSIs in other states? Again, we're going to use the same PSIs. You heard about those before, so I'll skip over that. The theory is real simple, right? Deterrence. Tort law should deter bad quality, right? That's a lot of what we think it does. Does that actually happen in healthcare? Well, we don't really know, right? Do providers get less careful if we ratchet down the med-mal risk? The hypothesis would be that we do, but empirical question. What we find is we actually do find that PSI rates rise, both for selected individual PSIs and for our pooled measure that's consistent with this naive deterrence theory. You'll notice that the combination is maybe not exactly what the reform proponents hope, which is that tort reform reduced quality without reducing spending. Although maybe they just wanted it to reduce med-mal, and it did that. So very limited prior research on the effect of med-mal risk or med-mal reform on healthcare quality. So Michelle Mello just walked in the room, so she's got a survey paper last year. The evidence of the effect of tort reform on quality care is too limited to draw conclusions. Okay, so we're going to draw some conclusions. So I've given you some papers that find no effect, a couple that find a small effect, but hard to find much of an effect there on the whole. What are we going to do? Study period 1999 to 2008 so far. We've got this Texas hospital inpatient data set. Our controls will come from the national inpatient sample. This is a 20% random draw of hospital discharge records from most states. We've got about 72 million discharges. So we build a nice big Stata server because we're running regressions on 100 million observations in some cases. The basic method is going to be difference in differences, where this is a simple specification. I'll give you fancier ones later on. Right, we're going to ask whether the PSI rate for each of the PSIs, that's the J, right, in state I in year T is going to be a constant plus a coefficient times a reform dummy. That's going to turn on in Texas after reform. It'd be 1. It's going to be 0 in not all other states, and 0 in Texas before reform. And we'll have time dummies, and we'll have state dummies. So this is going to be a state fixed effects specification. The core assumption behind any difference in difference analysis is, would there have been parallel trends without reform in Texas relative to control state? That's one. We'll control for that in part. And second, that nothing else happened in Texas or elsewhere that would cause Texas to diverge from the control state. And we're not aware of anything else, but that doesn't mean there wasn't anything else. One problem here is we have only one treated state. One of our extensions will be maybe we can find a couple more states to study. So here's an example. Here's PSI 7, which is CLABSI, central right bloodstream infections. And so this is one of the ones that's consistent with our hypothesis, right? Before reform, no difference. I've got 3 different measures of the control group. One is a fully balanced, which means we have the same control states in our sample for the full time period. Now, states come in and out of the national inpatient sample, so that's a narrower control group. We also had approximately balanced, which is they have to be in the NIS for 3 years before and 3 years after a reform period. And then unbalanced is just, let's just throw in all the data we've got. And the control group doesn't matter. I've shown you 3 lines here. I won't bother with the 3 lines. I'll just use the balanced controls and anything. And what you see is, well, it sure looks like there was a divergence after reform, right? Texas got worse than other states. That doesn't prove that tort reform caused the divergence, but it's suggestive. In addition to looking at the individual PSIs, we're going to use this pooled PSI measure. We're going to add up the individual PSIs. We're going to normalize each of them so that we don't weight the more common ones more heavily. And then we're going to normalize them again. Okay? And that's effectively giving equal weight to each of the PSIs. Here's what the pooled rate results look like graphically. And you see a bunch of wiggles. Well, gee, I wish it was nice and smooth. But nevertheless, it looks like Texas is getting worse relative to the balanced controls or the other measures of the controls. And it takes a while after reform. It's not like there's a sudden jump. Like it takes a while for plausibly something to change in the world. Okay, so another question that we work on is, it looks like we're not seeing a sudden jump after reform. It looks like we're seeing diverging trends. So our specification here is going to allow both for a jump after reform in Texas, a change in trend after Texas. So it's going to be reform times a time trend variable. And then we're going to control for state-specific trends both in Texas and in other states. And one thing to discuss is whether we should be doing that, whether there was reason to think there should be differing state trends. Okay? So PSI rate on a reform shock and then a post-reform trend. And what are we going to get? This is a lot of numbers, but what I want to show you here is green means Texas gets worse after reform and is statistically significant. Okay? Yellow means Texas gets better after reform and is statistically significant. And there's more green than yellow, and the pooled effect is strongly positive. And then if you go back to the graphs, the kinds of ones I showed you before, for the 2 that are negative, where Texas is getting better, one is pressure ulcer and the other is post-operative physiological derangement. Not sure exactly what it is, but it sure sounds bad. You see nothing in the graphs. So this is a result that's coming out of including the state-specific trends in the regression. Now, I think of state-specific trends as a good robustness check on a result I've already got. I'm not sure I trust the result that I see only because I add them in. So I want to say that the 2 that are going the other way actually are not robust. And everything else is either neutral or going against Texas. Another thing we can do, this is state-level PSI rates, is we have individual patient-level data, right? We can throw our 100 million observations onto a nice big server and do a patient-level analysis. I'll show you results with linear probability regressions, but Logit is going to be similar. Same coefficient, only we're predicting whether this patient got a PSI, a bad thing, and we're going to throw in, this should be a coefficient here, we're going to throw in patient characteristics. Okay, so now we have patient-level data, we can throw in patient characteristics while we're at it. And what are we going to get? Again, we're going to see more green than yellow, which means Texas is getting worse. I didn't show you the pool at the bottom because we hadn't run it yet, but we've now run it without the state-specific trends, and it's positive and it's got a t-stat of about 5.5. So the pooled result is Texas is getting worse. The 2 that go the other way are the pressure ulcer again, but that's not robust. And then this time, number 3 is negative where it wasn't before. Then we can put the 2 together, and say, well, it looks like Texas sure ain't getting better, and maybe it's getting worse, and I've got a plausible claim for causation. We've got an exogenous shock. The ones that are consistent across both the state level and the patient level regressions, PSIs 5, 7, 9, 15, and the pooled results all go against Texas. PSI 3, which is the pressure ulcer, goes in Texas's favor, but again, only with state-specific trends that we see the divergence emerges over time. So this is at least a little bit of evidence that tort reform might have an effect on overall quality. Then we wanted to ask, how much of a practical difference does this make? Okay, we have statistical significance. Do we have real-world significance? And so overall, this is our coefficient on the jump and then the trend, and we got 20-time periods. So by the end of the period, the aggregate number of PSIs is going up by almost a standard deviation. So that's enough to worry about. That's about 10%. And then for the ones that are individually significant, we get higher percentage increases in the 20 to 30% range. So what are we going to do next? We want to extend the data set. That will help with statistical power. We'd like to look at other states with tort reform over the 2003 to 2006 period. But we need a state that both has tort reform and has a state-level database. That's a sample of 4, and we'll go study the other 3 in Florida, Nevada, and South Carolina. We can also look at other measures of care quality. So there's a broader measure called the Utah, Missouri Adverse Event Classification. And then we've got these relatively recent HHS mortality and process measures. The problem with those is they don't stretch back to our before period. So I'm not sure how much power, how much extra value we'll get out of them. But Utah, Missouri, we want to be able to use. So policy implications. Med-mal risk may deter some preventable adverse events. Maybe this is part of a reassessment of the benefits and costs of limiting med-mal losses. Right? So providers love to limit med-mal. No one says med-mal is doing a great job of deterring low-quality care. How do we know? We have med-mal and we have lots of low-quality care. But if the effect on healthcare spending is weak or absent, and there's an adverse effect of reform on quality, which is consistent with naive tort theory, maybe you're less excited about nationwide caps on non-economic damages. And then we were asked to put a dissemination slide, and we're interested in med-mal reform, at least for those who are persuadable. We don't think the providers are persuadable. Policymakers ought to be interested in healthcare quality. Maybe this is a piece of the quality mix, though med-mal surely isn't all of it. How do we reach them? Not sure, but whatever publication outlet we use for both projects has to work for Zeno. Because he's a PhD student, eventually he'll need a job. That's it.